Good afternoon, everybody. Can everybody hear me?
Yes, we can hear you. Thank you.
Great. And evening, some of you, good evening. My name is Vicky Morton. I'm in Charlotte, North Carolina, and work with the EBPOM group, putting together the conferences that we have been doing. And really excited about this one coming up. Supposed to be live in Chicago with everybody there. However, as we all know, we are forced to do virtual, but I think it's going to be a great conference, and I hope that you all attend as many sessions as you can, and then would love your feedback. I have everybody pretty much marked off. I'm missing a couple of people. Let's see, somebody just joined, thank you. Okay. Is Manpreet on? Oh, okay, hey, good. Your name on your screen says EBPOM, so I wasn't sure. Okay, great. I think we have everybody then accounted for. So basically, y'all, we are going to choose 3 abstract finalists. We have 2 more sessions of abstract video face-to-face presentations, and then we will be sending out the 3 finalists. We had a lot of great abstracts, and I'm really excited to hear from you all today. As you know, this is going to be for our Chicago conference. The next EBPOM conference coming up is Dingle, Ireland, and then after that, late January, a Las Vegas conference in conjunction with the American Society of Anesthesiologists. So again, my name is Vicky Morton. I'm a nurse practitioner and director of clinical and quality outcomes for an anesthesia group in Charlotte, North Carolina, and oversee our enhanced recovery program in 9 hospitals and 17 service lines currently. If you at any point have any questions about somebody's presentation, feel free to use the chat button, or you can speak up after the person is done presenting. I have on the timer 6 minutes for everybody, and we really need to try to stick to that schedule. Once you hear that timer go off, we really need to move on to the next person. We've got 9 abstracts today, so we have a lot to get through. Just so everybody is aware of the order, so you're not left wondering when you're coming up. We've got Dr. Singh first, and then Anjali, Sarah, and Claire. Shilpa, Manpreet, then Sorcha with the intubation of a child and the use of dexmedetomidine, Amanda, Amy, and then again Sorcha on the fitness wearables. So that's the lineup for today. And okay. So I'm going to go ahead and, does anybody have any questions? Okay. I'm not the best at the Zoom, so hopefully, can you all see that?
Yes. Yes.
Okay, great.
Yeah.
Okay. So you are up, Dr. Singh.
Hello everyone. Today I'll be presenting an abstract on late onset postpartum eclampsia. Don't ignore the headache. Preeclampsia and eclampsia continues to be a poorly understood neurological entity of pregnancy that substantially contributes to a maternal morbidity and mortality. The onset of postpartum eclampsia occurring after 48 hours after the onset of postpartum period is called late onset postpartum eclampsia. Here we have a case of 27-year-old normotensive woman with uneventful pregnancy till 32 weeks of gestation, who presented with chief complaints of pitting edema in both legs. History of presenting illness, she only had pitting edema in both legs, otherwise her pregnancy was uneventful. There was no history of any headache, abdominal pain, blurring of vision, any seizure, or any decreased urine output. Her past history, obstetric history, personal history, family history were all non-significant. Pre-operatively, her heart rate was 78 per minute and her blood pressure was 150/90 millimeters of mercury. but she was normotensive during her 32 weeks of gestation. All her investigations were in normal limits, except for protein levels, which was done by urine dipstick. It was 0.3 gram per liter. After admission, she was started on tablet labetalol, 100 milligrams TDS, but her blood pressure kept on rising over her next 2 days. She started complaining of dyspnea, and then on chest auscultation, they were bilateral trips. She was then started on hydrolysin infusion and oxygen by face mask, and she was shifted to operation theater for emergency cesarean section. Intraoperatively, she was given general anesthesia, which was uneventful, and then she was shifted to ICU for post-op mechanical ventilation. In ICU stay, she was doing really good, and then she was weaned off gradually from mechanical ventilation after 32 post-operative hours, and then hydrolysin was gradually tapered, labetalol was restarted. Her blood pressure readings came down to normal. All other vital parameters were also normal, including urine output. On 5th post-operative day, when patient was being planned to shift out of ICU, she complained of sudden onset of throbbing headache, which was occipital, and it didn't have any other danger signs. Her blood pressure at that time again was normal, and her other vital signs were unremarkable. On examination, her neck was supple, non-tender, pupils were bilaterally equal and reactive to light. Neurological examination was absolutely fine, except for increased deep tendon reflexes. She literally had a generalized tonic-clonic seizure at that time, lost her consciousness for 2 minutes, and that GTCS was being terminated by giving midazolam. And although she got a bit drowsy, but her blood pressure was still within normal limits. So provisional diagnosis of eclampsia was being made despite the fact that her blood pressure was normal. So we gave magnesium sulfate infusion, and we were not sure that whether it was eclampsia or any other conversion at that moment. So we gave phenytoin 1 gram as well. Her hematological examination was normal, including complete blood count, liver function test, kidney function test, except for uric acid, which was around 8.9 milligram per cent. Her unique catecholamine levels were absolutely in normal limits. Her CSF cytology and culture was negative. Her CT scan, which was done few hours, revealed no gross abnormality. She was absolutely fine for the next 48 hours, therefore shifted to ward and then discharged home without any neurological sequelae. So in discussion, our patient had LPE, that is called late onset postpartum eclampsia, as she developed seizure on 5th postoperative day. Diagnosis is being based on the clinical course, that is having pregnancy-induced hypertension. Although she had a very short duration, before 32 weeks of gestation, she was fine. And we have excluded all other causes doing the investigations and CT scan. We had a differential diagnosis of encephalitis, meningitis, epilepsy, electrolyte abnormalities, or any metabolic abnormalities, any space-occupying lesion, vasculitis, venous thrombosis, stroke, or any side effects of epidural analgesia. And she had a drastic response to magnesium sulfate, and we have excluded all other causes, and CT scan was normal. So therefore, it supported towards the diagnosis of eclampsia. There have been 2 authors, Lubarsky and James, who also reported that 44 and 79% of their patients with LPE had no preeclampsia before the seizure onset. And Santos stated that headache was the most common symptoms of impending eclampsia. All the reported cases of late onset postpartum eclampsia have been associated with high blood pressure. But in our case, the blood pressure was absolutely normal, and she was being planned to shift out of ICU. And at that time, she developed a seizure, along with headache. Otherwise, she had no other visual disturbances. So diagnosing this clinical entity is actually a real-time challenge. And late onset postpartum eclampsia is considered as a type of subtype of eclampsia. So therefore, the therapeutic approaches remain the same, and therefore magnesium sulfate remains the mainstay of treatment. So we can conclude that headache, or with or without visual disturbances in the postpartum period, can be a prodromal sign of late onset postpartum eclampsia, even in normotensive patients. And therefore, early diagnosis with subsequent initiation of anticonvulsants and antihypertensives remain the mainstay of treatment with preventive complications. Thank you.
Excellent. Does anybody have any questions? We just have a few seconds. Okay. How did the patient do after she moved out of the ICU, and did she stabilize well and everything else was good? She went home and no issues? Right.
No issues. Yeah, no issues. She was absolutely fine. Yeah.
Right. Had she
And
had, was this her, I can't remember, was this her first? This was not her first. Did she have any issues with her previous
no,
pregnancies?
she already.
Wow.
No,
Very
not at
interesting.
all. And even she delivered one baby afterwards. Also, she was fine.
All right, I'm going to go ahead and move down to the next one. I'm trying to find the presenter view on here, and I'm having a hard time with it. So that's why all of our pictures are showing up on the side.
Sorry, it's Anjali.
Yes. Anjali, you, hang on 1 second. Okay. All right, you're good to go.
All right. Hi, my name is Anjali. I'm one of the registrars in one of the hospitals in London. And I'm going to present an audit that we did in our trust over 2 sites. And the audit was on peri-operative anesthetic record keeping. So the anesthetic chart is a valuable medical, legal, and scientific document, and it is the principal responsibility of the anesthetist to establish the acceptable standards of patient monitoring and to document pre-operative assessment, intraoperative management, and physiological parameters, along with clear instructions for post-operative recovery and discharge. So the main aim of our audit was to analyze the completeness of peri-operative record keeping by the anesthetist of our hospital and to recommend changes in practice to improve the compliance. The good practice guidelines given by the Royal College of Anaesthetists and the Association of Anaesthetists of Great Britain and Ireland in 2006 clearly states that the requirement of data to be documented by the anesthetist and also establishes the requirement of both legibility and completeness. So for our, so the methods which we employed for our audit was that we did a retrospective audit by looking up the anesthetic charts over a period of 3 months, starting from December to March. And we developed a questionnaire based on the hospital anesthetic chart for recording the findings. The parameters analyzed can be broadly divided under pre-op assessment, procedure details, intra-op record, and the post-op period. So under the pre-op assessment, we looked out for the patient's name, surname, hospital number, date of birth, the patient details, the signature of the anesthetist, along with the date, regular medication of the patient's, ASA score, allergies, airway assessment, and consent opt-in. Just a piece of information that the pre-assessment in our hospitals is carried out by the nurse. So we have a separate booklet for the pre-assessment in which the nurses record the entire medical history of the patients usually. So that's a separate booklet which we have apart from on top of our anesthetic chart, and also the pre-induction values which are recorded by the nurse are written down in that booklet. Coming to the other parameters that we analyzed the procedure details such as the date of operation, name of operation, site of the surgery, name of the anesthetist, and the name of the surgeon, the consultant responsible. The parameters analyzed in the intra-op record were the pre-surgery checklist, which included the WHO checklist, whether it was done or not, just a tick box, and the machine check, the anesthetic machine check, the AGBI monitoring checklist, whether they were done or not, additional safety measures like whether patient warming was on, whether the DVT pumps or the TET stockings were on, patient position, airway device use, induction drugs and dosages, local or regional anesthesia record wherever applicable, and observations. We just looked up for heart rate, blood pressure, pulse ox, and capnography. Total IV fluids, blood and blood products used, total blood loss and urine output. And in the post-op period, we look for the clear post-op instructions and also any critical events present or absent. So even if it was absent, in our anesthetic chart, it's either yes or no. It's never not applicable. So if it's absent, it should be recorded as no critical event. The findings of individual parameters were either yes, no, or non-applicable. The target compliance for all these parameters were taken to be 100% as per the good practice guidelines by RCOA. The cases done on emergency list and those who were sent to the ITU or HDU were excluded, because it's a general practice that, you know, if a patient is on the emergency list, or if the patient is going to the intensive care, the documentation is usually more complete. So just to keep away from the bias, we kept away these patients from our audit. The results were, we analyzed 107 charts, and we found that we had suboptimal completeness in quite a few of these parameters. So in some cases, the patient's date of birth was not noted. So in our hospitals, we do a 3-point patient identification, that is the patient's name, date of birth, and the hospital number. And in few cases, the date of birth was not noted down. The anesthetist, the date of the signature of the anesthetist on the front of the chart was not there. So they signed the charts, but they did not put the date. The medication charted was only 89%. ASA score was noted only in 85%, airway assessment in 94%. Consent, which according to good practice should be 100%, it was only found to be 49%, which means the anesthetists probably have taken a verbal consent, but then have not documented that. The site of operation was only documented in 89%, name of the surgeon in 88%, pre-surgery checklist 54%, AGBI checklist only 97%. Among the vital parameters recording, blood pressure and capnography was not recorded in about 2% of the cases analyzed, and post-op instructions was not noted down in 45% cases, and according to the good practice guidelines, it should be 100% as well. Critical event recording was only done in one case where the critical event was actually present, but in other cases where it was absent, it was not recorded whether that it was absent. So if when we looked at the maximum completeness, it was found that 96.7% was the maximum completeness of chart, and the minimum was 66.7%. So to conclude, the level of compliance among the anesthetists in our hospital was obviously suboptimal as per the guidelines of RCOA and AGBI. So we recommend training and sensitization of the anesthetists about the importance of perioperative documentation, and also we have put up some alert messages in the hospital, because it has been found that there are several factors why anesthetists fail to complete their chart. It's probably because the chart does not have enough space for them to write down, or probably there is lack of alert messages that they forget to write, or probably the turnover rate of the cases is so high that often we don't have time to document everything, or it's perhaps that enough time is not spent to actually document this very important medical legal piece of information. Just quickly, the limitation of study was RCOA also recommends that the charts should be legible, which we did not analyze in our study. So maybe on a future audit, we would include that. And we plan to conduct a re-audit after we have put up this alert messages in our theaters to assess the impact of these changes. Thank you very much.
Great, thank you so much. All right, let me get on to the next one here. 1 second. Okay, there we go. Speaker view. All right. Sarah and Claire?
Hello.
No.
My name is Sarah Woods and I'm here with my colleague Claire Luck. We're both pre-assessment clinical nurse specialists. We're working at Cambridge University Hospital Trust, and we're going to be talking to you about fit for surgery, which was our Prehabilitation service development project, which we were involved in. So we're just going to go through different aspects of the slides. I'll start off with the introduction and some of the methods, and then I'll hand over to my colleague Claire. So we found that the pre-operative period is really a really excellent time for interventions such as lifestyle changes to occur, as patients are really more likely to be motivated whilst awaiting surgery. We wanted to establish a sense of ownership for patients preparing for surgery at home, so putting the emphasis on how their input can really improve their post-operative recovery. By optimising patients' functional capacities before surgery, we can really help them withstand their post-operative stresses, enabling a quicker return to their functional status. So our main aims for the clinic was to improve physical and mental preparation for surgery, manage expectations for surgery, educate about early mobilisation and chest physiotherapy, and advise on continuing these positive habits at home. So the methods that we used, we actually visited 2 hospitals within the UK with established prehabilitation programmes, one within Manchester, so the Manchester Royal Infirmary, and St George's Hospital in London. We also attended the World Prehabilitation Conference in London last year, which was an excellent chance for some networking with other colleagues. And we applied successfully for charitable funding to set up the pilot group. So our pilot group included patients from multiple specialities, those within colorectal cancer, gynecology, urology, HPV cancer surgery, and vascular cases. So we intend really to run our pilot over a year and audit the effectiveness on patient experience. And we really hope to be able to expand our service to other specialities and secure funding from our trust as opposed to relying on charitable resources in the future. So one of our first outlooks was to develop some resources to use within our session. So we developed a booklet, presentation, website, video, and we created posters to improve patient knowledge and understanding of the entire surgical pathway. So the key points covered in our presentation were smoking and alcohol cessation, diet, exercise, breathing exercises and pre-op physio, anaesthetics, pain relief, and information regarding the patient's pre-op surgical journey. We also created a video which we actually filmed on site with the trust, and that's a really comprehensive explanation of how to prepare for surgery at home, what to expect on admission, and what will happen during the recovery and discharge phase of their stay. We're also really lucky to have access to a great video from our colleagues over in the physio department of the Manchester Royal Infirmary. And this is a really detailed account of how patients get out of their day 1 post-op with all their drips, drains and infusions. And that's again just to give them a bit of education as to what to expect when they came into surgery. I'm just going to hand over to my colleague Claire to go through the remainder of the methods.
Hi, my name is Claire. So I'm just going to go through the implementation phase and the analysis. So Fit for Surgery started as a face-to-face session supported by resources designed to complement the programme and improve patients' knowledge of their pathway. Due to resources, we were only able to offer this service on alternate weeks. We had Macmillan, who are a UK-based cancer charity. They were there, able to send a representative to the face-to-face sessions, bringing leaflets and offering patient support networks. During the pandemic, we've had to adapt our clinic, so the delivery of face-to-face clinics had to cease after a few sessions, unfortunately, as elective surgery was temporarily discontinued at our hospital. We've since modified our service to run as a video conference in order to maintain social distancing. So the positive outcomes that have come from this are that we were actually able to increase our patient numbers due to not having to worry about room capacity. It's more convenient for patients as they don't have to travel to hospital for another appointment. And we've actually managed to increase frequency of clinics every week. We've also been approached about the potential to expand our service to cover the east of England. For the analysis, we're using the PDSA, which is the Plan, Do, Study Act, which is an NHS improvement tool cycle to evaluate and adapt our service. The team, we're currently in the Do phase of the cycle. And in order to measure our success, we intend to review patient feedback questionnaires to establish satisfaction, post-operative complications. So from the patient's feedback, we had 25 out of 29 patients attended the sessions, meaning we had a DNA rate of 14%. 22 out of 25 patients provided written feedback using our post-clinic questionnaire, and the average satisfaction was 9.14 out of 10. 22 out of 22 patients reported understanding the information provided, and 15 out of 22 will make some or many lifestyle adjustments after attending the session. So post-operative complications, we use the Clavian-Dindo classification tool to grade the level of complications patients experience. We retrospectively examine patients' care post-surgery to grade their adverse effects, including 4 out of 25 patients who are still awaiting surgery due to delays caused by COVID-19, 1 patient awaiting chemo and 1 waiting for a second opinion. The total patients who have attended fit for surgery are 19. 14 out of the patients scored 0, 3 out of the patients scored 1, and 2 out of the patients scored 2. So in conclusion, rehabilitation at CUH has the potential to positively impact the pre-operative status of patients, but we intend to re-evaluate our aims and objectives to review the effectiveness of the service. Thank you.
Thank you. That's great. Any questions? We have a couple seconds. Okay. Let me go to the next. All right. Shilpa? With frailty, prevalence in patients undergoing cardiac surgery and associated outcomes.
Hello, can you hear me?
Yes, we can hear you.
Hi there. Thank you so much for giving me this opportunity to present my work on presence of frailty and cardiac surgery. I am one of the anaesthetic registrars here at Liverpool Heart and Chest from United Kingdom. Frailty, as you're all aware, is an age-related decline in physiological reserve. Frail patients tend to not do so well, particularly quoting the Yanagawa et al. Cardiac frailty 3-strike model. You've got baseline vulnerability, you've got cardiac stresses and post-event stresses, and the 3 of them come together to create what is the poor post-operative outcomes, particularly with a silver tsunami with increasing age and frailty. We thought it would be a good idea to look at the prevalence of frailty in our hospital and see what can be done about it. Frailty is also an independent predictor for mortality, mid-term survival, and delayed discharges. Also, cardiac pathologies like atrial fibrillation, heart failure, and acute coronary syndromes are much more common with frailty. So we wanted to quantify the prevalence. We started off by collecting data over a period of a month, last July 2019. For these patients were the ones who were attending for cardiac surgery, valve surgery, and aortic surgery. So we looked at their clinical frailty scores. This was the Rockwood frailty score. And having collected the frailty scores, if anybody scored vulnerable and beyond, that was 4 and above, we also did a full Edmonton frailty score for these patients. After 30 days post-surgery, further set of data was collected to look at what their hospital stay was, their ICU stay, if they had any complications or if there were any problems at all. 59 patients were collected as part of this project. 67.5 years was the mean age, with majority of them being male patients. The frailty scores ranged anywhere between 1 to 6. We didn't have anybody in the terminally ill and the unwell stage patients. 1 and 2 had approximately 25%, which were really fit and well patients who were actively exercising, whereas 3 who were just managing well and vulnerable and beyond made up the majority of our patient set. 68% of the complications occurred in the frail, the vulnerable and beyond patients. To quote a few examples, 1 patient died from multi-organ failure. 1 with a frailty score of 4 was discharged to an NHS nursing care home. We had 4 patients with delirium in patients, and there were a few other complications which were mainly to do with cardiac arrhythmias. The length of stay, if we see, the vulnerable and beyond group stayed in ICU for 4.25 days, whereas the group which wasn't vulnerable stayed for 3.25 days. And the inpatient stay in the vulnerable group was 10.35 as against 7.25 in the non-vulnerable group. So with the pilot study, we noticed that we did not have enough statistical significance or the power to analyze the entire hospital outcomes, but we definitely noted that there was a prevalence of frailty and something needed to be done about this. So we decided to take it forward by introducing a peri-operative frailty bundle and incorporate it into our peri-operative pathway. This bundle would include an electronic-based frailty screening system using comprehensive geriatric assessment, and this would be done with a multidisciplinary team input so that we could record physical, mental, functional, and nutritional reserve on these patients. With the help of shared decision-making, a multimodal prehabilitation, and geriatric co-management, we wish to take this forward. And hopefully, once we have been able to successfully get this going, we'd like to re-audit and see where we are up to with these things. Unfortunately, with the pandemic, we haven't been able to take it forward, but that's something we'd like to do. So watch the space. Thank you very much.
We're really looking into all of this in our hospitals right now as well in cardiac surgery. Quick question. So cardiac surgery, is this all cardiac surgery, valves, bypass?
So we included bypass, we included valves, and we included aortic surgery because they were already trying to pilot this with aortic surgery, but we didn't include any thoracic surgeries in these.
What is your average wait time from decision to operate to the actual posting of the case in your cabbages for elective?
So it's anywhere between 4 to 6 weeks. Usually the pathway is the patient comes in to the pre-op assessment clinic and they have 4 to 6 weeks wait for a surgery. Post-surgery, majority of the bundle is offered to them, i.e. the full the rehabilitation care and the dietetics and physiotherapy, occupational therapy, which is where we saw there was an appropriate moment for intervention, which is to start earlier on in this pathway than to address it towards the end.
Absolutely. Okay. All right. Thank you very much. Very good.
Thank
you. Okay. Dr. Singh, you're back up.
Yeah. So thank you very much. So I will be presenting an abstract on tracheo-oesophageal fistula with pulmonary atresia, PDA with a single ventricle with tetralogy of fallot. So esophageal atresia with or without tracheo-oesophageal fistula is a common neonatal emergency, which may be associated with major life incompatible cardiac abnormalities. So survival of such neonate depends on the stabilization and the proper resuscitation followed by post-operative care. Here I'm presenting a case report of a 4-day-old male baby delivered prematurely at 32 weeks of gestation by cesarean section, whose weight was 2.29 kgs with a diagnosis of esophageal atresia with distal tracheo-oesophageal fistula, which was scheduled for right posterolateral thoracotomy with the ligation of distal tracheo-oesophageal fistula with end-to-end anastomosis. Pre-operatively, when the baby was assessed, he was presented with respiratory distress, frothing from mouth, and he was hemodynamically unstable with heart rate of 135 per minute and blood pressure of 62 over 40 millimeters of mercury. So he was started on inotropic support with dopamine. And at that time, his oxygen saturation on room air was 85%. He was taken for the surgery for right posterolateral thoracotomy. Surgery was uneventful, but the baby wasn't able to maintain the saturation even after the ligation of fistula, which is usually the case that after ligation of fistula, the saturation drastically improves in most of the cases. At the time of the reversal of the neuromuscular blockade, baby had active movements, and he was maintaining a saturation of 88 to 90 millimeters, 90% with 100% oxygen, and was on dopamine still. But he was having active movement, so we extubated the baby, and then post-operatively, he was maintaining a saturation of 85 to 86%, which was the pre-op saturation. And he was having active movements, he was fine. So he was shifted to post-operative care unit with oxygen through the nasal prongs. But after 3 hours of the surgery, his saturation started falling drastically, and he developed persistent cyanosis, and his trachea was then intubated again. Chest tube was inserted because on the right-hand side, the breath sounds were minimal. But after insertion of the chest tube, we ruled out pneumothorax, hemothorax, or pleural effusion. We couldn't do echocardiography before taking this patient to the emergency because of the emergency clinical episode of respiratory distress. But we had to conduct emergency 2D echocardiography at this moment. And we saw that there was a large VHD with the pulmonary atresia, with PDA, with a single ventricle, with tetralogy of fallot, which is actually life incompatible, and we operated. During his ICU stay, he became more hemodynamically unstable, so he was started on dobutamine along with dopamine, and he wasn't able to maintain saturation of more than 75% with mechanical ventilation, with 100% of oxygen, with pressure controlled ventilation. He was then started on prostaglandin 1 E1, that is alprostadil, and then shifted to NICU. Baby's general physical condition deteriorated over the next 2 days, and he died 2 days after the ligation of fistula due to the respiratory failure and cardiac arrest. So the figures showed that the group C abnormality, that is the tracheo-oesophageal abnormality, where the distal end of the esophagus is having a fistula with the trachea, is the most common one. So here we discuss esophageal atresia and tracheo-oesophageal fistula is the major congenital anomaly, and it is associated with life incompatible anomalies like single ventricle, along with PDA, VSD, pulmonary atresia, and then it becomes a nightmare and a real challenge for both the anesthetist as well as the pediatric surgeon to operate. And so success in survival of the neonate with esophageal atresia with tracheo-oesophageal fistula is attributed to improved neonatal care, anesthesia, and better understanding of the neonatal physiology. But unfortunately, in our institution where he was operated, we were not well equipped with the emergency cardiac backup, which if would have been there, then we would have saved the baby after successful ligation of tracheo-oesophageal fistula. So our 4 days old baby couldn't be saved, and he died of respiratory failure and cardiac arrest. Thank you very much.
Thank you. Interesting case. So quick question.
Yep.
And so if the baby had been a bit more stable prior to surgery, would it be standard of care to echo them prior to going into surgery?
I think that was being thought after this incident happened, and we even thought that the anomalies that were associated with the baby, I believe that was life incompatible. So ideally, we shouldn't have made a decision to operate him. But yes, if in a big cardiac setup, we would have everything available, we would have gone for the surgery. We have seen many cases in the other studies in which there have been times that around 2 to 10% of the patients have been saved after cardiac surgery.
Yeah, that's interesting. We have a big congenital heart program here in our city, and see several cases of tetralogy of fallot and from all over the place. So this is very interesting. Does anybody have any questions? Okay. All right. Thank you so much.
Thank you very much.
Okay. Sorcha, did I say that right?
Sorcha, yeah.
Okay, I'm sorry.
No, it's fine.
Challenging intubation of a child and the use of dexmedetomidine.
Yes. So good afternoon. My name is Sorcha Coleman, and I'm an anaesthetic house officer in University Hospital Limerick, which is in the Midwest of Ireland. So the case I'm going to discuss today is that of a 14-year-old boy who actually presented with a pterygoid abscess, which required drainage, and this obviously presented difficulty from an anaesthetic's point of view, as he had very reduced mouth opening. So the requirement for an awake fibre-optic intubation is uncommon in children. Dexmedetomidine is a selective alpha-2 adrenergic receptor agonist and the sedating agent of choice in our centre for an adult awake fibre-optic intubation in an anticipated difficult airway. Unlike most sedatives, dexmedetomidine causes no respiratory depression when given as a monotherapy to healthy subjects. Its duration of action is 30 minutes, and with its extended recovery time of over 1 hour, post-sedation agitation is lessened. Dexmedetomidine is commonly used in children in the intensive care setting, for up to 24 hours for its anxiolytic, sedative, and analgesic effects. These factors contributed to the selection of dexmedetomidine as our sedating agent for this child's awake fibre-optic intubation. So as I alluded to, a 14-year-old boy presented to our hospital with a 3-day history of reduced mouth opening, left-sided jaw stiffness, and coryza. He had no medical history of note and no previous dental or mandibular issues. He had no recent trauma to the area, no sick contacts, and no adenophagia. The boy's dental hygiene was poor. On admission, his inflammatory markers were raised. His white cell count was 12.2, neutrophils 8.7, and CRP 14. On exam, he had minimal mouth opening and palpable tender submandibular nodes. Following a multitude of imaging, X-rays, nasoendoscopy, ultrasound, and CT showed a left lateral pterygoid abscess, which following antimicrobial treatment required surgical drainage under general anesthesia. This posed obvious difficulties from an airway point of view, as the child's opening was restricted to a few millimeters. So this challenge was overcome using dexmedetomidine infusion of 1.5 micrograms per kilo per hour to perform an awake fibre-optic intubation. This child was ASA grade 1E with no anaesthetic issues other than the absent mouth opening. Following a discussion with both the boy and his mother, he was consented for an awake fibre-optic intubation. As you can see, there's a CT image of the lesion on the left side there, which is circled in yellow. As a result, it was in the left masticator space with mild edema in the mucosa. His left jugulo-digastric node is mildly enlarged, and his deep cervical lymph nodes were asymmetrical. So we brought this young man to theatre. In theatre, cannulae were sited and monitoring was attached as per the AAGBI guidelines. Dextor infusion was commenced. Initially 4 micrograms per mil infusion at 1.5 micrograms per kilo per hour. So Dextor comes in 1000 microgram in a 10 mil preparation, and this was diluted to 4 mics per mil. To reduce secretions in the oropharyngeal area, we gave him some glycopyrrolate, 100 micrograms. He received 4 of these aliquots. We also used nebulized 4% lidocaine to obtune the airway, and the fauces were also sprayed with lidocaine. In order to decrease his bleeding potential, cofenilcaine was sprayed in the nares, and the patient also gargled a mixture of 1% lidocaine and Instilogel. Coughing was encouraged to distribute this solution in the pharynx. 2 suction catheters were employed, a Yanker suction for oral secretions and soft silicone tubing to be attached to the scope if required. The patient was positioned at a 45-degree angle to perform the intubation. We used a 6.5 size nasal airway to dilate the nares initially, which was then followed by a size 7 airway, which was left in situ for 2 to 3 minutes. An epidural catheter was inserted into the laryngeal area, and lidocaine 1% was sprayed through it. So all these methods left a cooperative patient who was intubated following pre-oxygenation using a small ambuscope size 6, which is pictured, and a reinforced endotracheal tube. Tube position was confirmed by Untitled CO2 tracing prior to induction. So following all that, the surgery and anesthesia were subsequently uneventful. A large abscess was drained, which cultured a mixture of multi-drug resistant organisms. In discussion with the boy post-operatively, he was very satisfied with the level of comfort and the sedation provided by dexmedetomidine. Following the procedure, the boy's mouth opening actually remained restricted. He continued to receive antibiotics with physiotherapy advising manual stretching of the joint and tongue depressions. Over the following 4 weeks, his mouth opening improved to its premorbid condition. So just to discuss, dexmedetomidine is commonly used in children in the intensive care setting for up to 24 hours, as I mentioned, predominantly post-operatively. It is shown to be effective when weaning mechanically ventilated children, as it is not associated with respiratory depression, like, for example, fentanyl or remifentanil. In this instance, it has exhibited a similar safety profile as in adult counterparts, and there are many documented incidences of children receiving sedation with dexmedetomidine. However, this is the first instance of its awake fibre-optic intubation in a child. Its properties render it an ideal agent as there is less risk of losing the patient's airway, which is obviously a potentially catastrophic consequence. It also allows the patient to cooperate with the procedure. So we used 1.5 micrograms per kilo per hour of dexmedetomidine, which was effective. Thank you.
Great. Thank you so much, Dr. Coleman. That was very interesting. Okay, we're going to move on to the next. We're right out of time there. So Amanda and Svet.
Hello.
Hi there. Sorry, I messed up your name.
Sarah. I'm Sarah.
Hi. Thank you.
All right, we'll get straight on. So I'm Sarah Lester. I'm a specialist occupational therapist in the Prime service, and Amanda Saunders is a specialist physiotherapist in the Prime service here at Adam Brooks Hospital, Cambridge University. So the Prime service stands for the Peri-operative Review Informing Management of the Elderly, and this was a pre-operative clinic that we set up in 2014. And the team consists of Amanda and myself as the statics, and then we've got a multidisciplinary approach of 7 consultant anaesthetists that cover the clinic on rotation, 4 geriatricians and the same. So, and then we also have support from specialist nurses within the pre-assessment department as well. So we're one of a handful of such clinics in the UK. The clinics exist across the UK, but in various guises, such as some don't have an anaesthetist, some don't have therapy involvement. So we're quite unique in the fact that we have geriatrician, anaesthetist, and both occupational therapy and physiotherapy involvement within one multidisciplinary clinic. So everybody in the team specialises in peri-operative medicine and prehabilitation. So the clinic was initially set up in 2014 on a year pilot scheme, and it did so well that it was then made substantive by the trust. So I'll just hand over to Amanda for the next bit.
So just to tell you a little bit more about the clinic, we run 3 clinics a week, which covers 18 patient slots. We also have our sister service, who you heard from earlier, the Fit for Surgery team, who see the non-frail patients. So to be referred to our clinic, patients need to be over the age of 65, score 4 or more on the Rockwood frailty scale, and then they need to have some kind of nurse concern about their comorbidities. Once the patients are referred by our brilliant pre-operative nurses, we see them in our clinic. So we see them for a 90-minute appointment, which is split in half between our medical colleagues, our geriatricians and anaesthetists, and myself and Sarah doing a comprehensive therapy assessment. After this assessment, patients generally fall into one of 3 categories. So they're either fit for surgery, perhaps with a few recommendations for their management. They fall into the middle ground, where they're potentially fit but need further investigations to decide that, or they are not fit for surgery, and we then have to liaise closely with their surgical teams to discuss their onward management. So in the clinic, we would do lots of different types of things. It depends on the patient's presentation. The medics tend to do things like change medications, change doses, or stop things before surgery. They might order further investigations, echoes or other scans. And myself and Sarah generally provide equipment for the post-operative period, exercise programs, falls assessments, and those kinds of things. So once we have seen our patients, we collect retrospective data of their admission, which is what Sarah is now going to talk to you about.
So over the past 6 years that Prime has been running, we've seen a general trend of increasing patient numbers. So initially we started off with 2 clinics a week, and then this has now increased to 3. So this was also due to an increased knowledge among our colleagues in the hospital that became more aware of our service and the benefit that it was having to patients, and also the importance of adequate pre-op preparation was in higher demand as well. So when we look at some of the statistics. There's 41.8 with a score of 5 or more on the Rockwood, and with the majority of the remaining patients scoring 4 or more, which does equal vulnerable and comes into our frail category. Important to capture sort of the vulnerable people, as the surgery could be their precipitating event, which actually just tipped them over the edge into that sort of long-term frailty bracket. And that's something that we're obviously trying to avoid as well. Our length of stay data has been really encouraging, and we've proved over the last 6 years that frailty now at Addenbrooke's does not indicate a longer length of stay following prime team intervention. So we've had an increase in percentage of patients achieving a length of stay up to 68%, and that was last year's figures, and it was 47% back in 2017, so we've seen a really good increase there. We've also seen an increase in patient-led cancellations, and this is thought to be a result that actually patients are actually being fully informed about the risks and the benefits of surgery. And this isn't just from a medical perspective, but we're talking about from a physical and from a functional and also from a cognitive perspective as well. So we do have a very in-depth discussion with them, and it's quite a frank discussion at times in the pre-op phase. We've also had brilliant patient feedback. Overall, patients appreciate having a long appointment with multiple disciplines as well. They say that it gives them time to talk and to think about their up and coming surgery and all the things that might involve. And the positive things is that it helps them prepare for their recovery journey and what to expect from admission as well. Back to Amanda.
So just to touch on our changes during the pandemic, clinics were obviously suspended during our UK lockdown as elective surgeries weren't happening, and a lot of us were redeployed elsewhere. We are now operating via telephones or video appointments depending on what's convenient for the patient, and we are seeing a very small number of people face to face if video or telephone calls aren't feasible. Just to sort of round it all up, we have used an MDT model to significantly reduce the post-op length of stay across all different surgical specialties for frail older adults at our hospital. Our patient feedback has been brilliant, and we're really encouraged by the appreciation of the service by our patients and their next of kin. And going on from here, we're hoping to work on a post-operative service, but that is very much still in the pipeline and is a bit of a long-term project. Thank you.
Thank you.
Thank you. Thank you. That was wonderful. So the Prime Clinic, how many of are you guys the only one in the area, or do they have them in other areas of the country?
I think we're the only one in the east of England, certainly. Yeah. Our service was based on, I don't know if you can hear me with this on, our service was based on a similar service down in London at St Thomas's Hospital called POPS, but they have a slightly different setup to us, don't they?
Yeah.
They don't have a physio.
They're very, it tends to be more nurse and geriatrician led. They don't have an anaesthetist, I don't think, in their service either. They still have a multidisciplinary approach, and we based ourselves in their model, but our model is somewhat transformed over the years into something maybe a little bit more individual.
Mm-hmm. It's wonderful. Does anybody have any questions at all? Okay, great. Thank you so much.
Thank you.
Okay, Amy, peri-operative care of diabetic patients undergoing emergency surgery.
Hi, my name's Amy. I'm one of the anaesthetic registrars in Leicester. So I'm going to be presenting my audit on the peri-operative care of diabetic patients undergoing emergency surgery at Leicester General Hospital. So diabetes affects about 15% of the surgical population, and this cohort of patients has an increased complication and mortality rates during surgery, and thus affecting their length of stay in hospital. So it's really important to have good perioperative blood sugar control so it can reduce these risks. The Joint British Diabetes Societies published guidelines for the management of diabetic patients back in 2016. And there's been subsequent studies by NCPOD that have shown that perioperative, there's room for improvement in the clinical care of up to 35% of these patients. So we conducted an audit looking at the adherence to local trust guidelines, which are based on the Joint British Diabetes Society guidelines. And the aim was to have 100% adherence to these. So we analysed the perioperative care of diabetic patients undergoing emergency surgery, and this was done retrospectively. So 31 diabetic patients were identified, and the graph shows the type of diabetes that each patient had. So most of them, 43%, were type 2 diabetics treated with tablets, and the patients underwent a range of different surgeries, from abscess, incision and drainage to much larger operations such as renal transplants and laparotomies. So the majority of the patients had a general anaesthetic, and we found that during their preoperative assessment, only 13% had a HbA1c documented on the anaesthetic chart, despite 90% having a recent HbA1c level result available. The range of the HbA1cs was from 5.9 to 11.4% in our patients, and a pre-op capillary blood glucose was documented on the WHO surgical checklist in 84% of cases. 48% of our patients had a variable rate intravenous insulin infusion, and there was only one patient that fulfilled the criteria for an insulin infusion that didn't receive one, and this was for a short surgical procedure. Out of those patients that were on an insulin infusion, only 20% had their insulin infusion documented on their anaesthetic chart, and 47% had a CBG level of more than 11 millimoles a litre whilst on an insulin infusion. Only 40% had an hourly CBG documented on their anaesthetic chart, and on discharge from recovery, 81% had their CBG checked and documented. However, there were only 26% had their CBG checked regularly post-operatively until they were eating and drinking again regularly. So in conclusion, we found that overall that the perioperative management of diabetic patients undergoing emergency surgery was poor, despite these guidelines having been in place for several years. And as a result, we have developed summary posters for the management of diabetic patients, which will be displayed in every anaesthetic room. And the posters will also be uploaded on the hospital intranet to provide a quick reference guide. And the results will be presented locally to the department for discussion and education, and we will re-audit as well.
Thank you.
Thank you.
So when do you expect that you will re-audit again and present your findings after the intervention?
Well, we plan to soon. At the moment, because we've kind of on a summer break with the audit meetings, but hopefully end of September, I think whenever the next audit meeting is, as soon as it's presented, we plan to re-audit and see what the numbers are looking like.
Well, you should then resubmit this to Dingle with your new audit on there, since instilling the intervention. It'd be very interesting to find out how that went.
Yeah.
Any questions at all for Amy? Very good. Thank you so much.
Thank you.
All right. Last on our list today here, Sorcha, Dr. Coleman, use of fitness wearables to promote early mobilization in the early post-op period for patients.
Thank you. So I'm going to discuss the use of fitness wearables to promote early mobilization in post-operative colorectal patients. So as you are all aware, I'm sure, early mobilization post-operatively has many benefits, including reduced muscle loss, decrease in post-operative ileuses, increased gut motility, decrease in hospital-acquired pneumonias, and decrease in venous thromboembolic events. Lack of mobilization reduces gut motility, causes constipation, which is also exacerbated by concomitant opioid use post-op. At our centre, the importance of early mobilization is communicated to patients at their pre-operative assessment. In keeping with our local ERAS guidelines, patients are encouraged to dangle their legs from their bed on the evening of surgery and from post-operative day 1 to ambulate on the ward, and when they are able on the adjacent corridor. Patients receive multimodal analgesia to allow this. Urinary catheters are removed and tap blocks are employed as opposed to epidurals. To further encourage this, we provided 21 patients with wearable step trackers to incentivize early mobilization. All of these patients had undergone extensive laparoscopic colorectal surgeries. 12 of the 21 had anterior resections. We communicated a target of 1,000 steps to all patients on the anaesthetist post-operative ward round after the surgery. Patients were advised to ambulate 4 to 6 hourly during waking hours. The patient's nurse then recorded the steps in a paper record chart. The step count was recorded for post-operative day 1 and a portion of post-operative day 2 prior to the patient's discharge from our post-operative care unit to a general surgical ward. So our results were very encouraging. Step counts ranged from 510 to 3,100. 7 patients had step counts of below 1,000, and the majority, 14, had step counts of above 1,000. Patients aged raised from 57 to 81, and the average patient age was 70 years. Patients were more focused on reaching their required steps than previously and spoke about their walks with nursing staff and the consultant anaesthetist. Patients inquired regarding their fellow patients' step counts as if they were in competition. In conclusion, the use of fitness wearables is a novel addition to our local ERAS practice. All major post-operative patients are encouraged to dream, which is drink, eat, and mobilize, and the use of wearables encourages patients to ambulate. Some patients also purchase step trackers on their discharge, which encourages them to be more active in the long term. Thank you.
That's great, thank you. So the hospital provides the wearable for the tracking of the steps?
The consultant anaesthetist actually bought, so at any one time you would only have 4 or 5 patients in, this is over a course of weeks. So she actually bought them herself. Her interest is in the ERAS and really promoting that. So the agreement was that she purchased the fitness wearables and the colorectal surgeon actually purchased a coffee machine to encourage caffeine intake in patients. So,
that's great. Great trade-off. Okay, very good. Does anybody have any questions for Dr. Coleman?
I think it's just fantastic that they've used the fitness wearables. It is just spectacular that you're using that to encourage patients. You should even have a share invite option on those, I guess.
Yeah, they're very competitive, the patients. If you encourage them to do something, they say, are they the only one? Have they got more steps than their neighbor? Or well, they are here anyway.
It's brilliant.
It is. I love it. We in our ERAS program have talked about that, but we can't get it funded, and so the majority of our nursing units, they have a ambulation board posted, in a very common area with magnets, and it's a grid, and so we have the room numbers listed, and the patients that are in that room, they move their magnet to how many times they ambulated that day. And it's the same thing. They become very competitive with each other, and who has the the most boxes under their belt for the day, and I think that's great.
We actually did a study with wearables here with our frail patients pre-op, Have you done anything with your pre-op patients to see if it increases their activity at all?
We haven't used them pre-operatively for that reason, that it's actually just the anaesthetist that has done their surgeries is giving them the fitness wearables. But it definitely, yeah, I can see how that would encourage them even before they come in.
Yeah.
This was actually done in the run-up to Christmas last year, so that was where that patients then were asking for fitness trackers for Christmas, was what they were telling us from their families. So.
That's great. Well, if Apple Watch sales go up, we probably should have you guys to thank for that. All right, well that concludes our abstract presentations today. Everybody, these were wonderful. Great hearing from you, and a lot of great things happening out there, and great work being done. Like I said, we have another session tomorrow morning, and I believe tomorrow evening, and then you'll be hearing back from us for the top 3. If you have any questions in the meantime, don't hesitate to reach out. Anybody have any questions right this moment, or any feedback? All right. All right, well, I've enjoyed listening, so thank you so much.
Thank you.
Thank you.
Take care.
Bye.
Bye.
Bye.